días. Muchas gracias los que estéis conectados detrás de la pantalla, que no nos podemos ver. Entonces, pues bueno, desde el Servicio de Medicina Interna nos parecía que el tema que Maite va a desarrollar es un tema muy importante, muy serio y además cada vez más frecuente en nuestros hospitales y en nuestros pacientes. El título que ha elegido Maite, bueno, pues es Polypharmacia, el síndrome silente. Creo que es un título muy acertado y creo que no voy a decir nada más. Maite nos va a contar cosas muy interesantes y que espero que os guste y que surjan muchas preguntas después de la sesión y estará encantada o estaremos encantados de resolverlas. Pues nada, adelante, Maite.
Good morning. I'm Maite Ganchegui. I'm a fifth-year resident of internal medicine, and as they already said, I'm going to talk about polypharmacy. This is the index I will follow during my presentation. First, I will give you some background information, and then I will focus on polypharmacy itself. I will talk about its definition, the prevalence of polypharmacy in Spain, its impact on our population, and which part of our population is more vulnerable to its impact. And then I will finish with an approach to appropriate polypharmacy. So first of all, I would like to give you some background information. As we all know, people globally are living longer. For example, in the Basque Country, the proportion of people older than 65 years is already the 22.5%. And this pattern will increase over the years. According to some studies, by the year 2066, elderly people will represent the 35% of the population in Spain. This demographic change is becoming a challenge in modern medicine because as the population grows older, so do the chronic diseases and the number of medicines needed for each patient. However, it's remarkable that most practice guidelines are focused on one single disease and don't take into account the clinical complexity of each individual, especially the elderly. As you can see in this study made in the year 2012 by some Italians, published in the New England Journal of Medicine, they studied the characteristics of the people taking cardiovascular drugs and the people that were enrolled in trials studying these cardiovascular drugs. And as you can see, almost the 40% of the patients taking cardiovascular drugs in Italy had more than 75 years. But on the other hand, when they looked for the people that were enrolled on those clinical trials testing these drugs, only the 10% of these people were older than 75 years. And I think this is very important because as we age, medication affects us differently. And medications that were good when we were younger may not be the best option when we get older. So what does polypharmacy mean? We have two definitions to describe polypharmacy, the quantitative and the qualitative. Quantitative definition would mean that the patient is taking 5 or more drugs per day. And we call it excessive polypharmacy when the patient takes 10 or more medications per day. On the contrary, qualitative definition doesn't take into account the number of drugs the patient is taking, but focuses on whether those drugs are indicated or not. And it separates polypharmacy in two groups, appropriate polypharmacy or inappropriate polypharmacy. Appropriate polypharmacy would be the one where benefits outweigh the risks, where there are some therapeutic goals that are being achieved or we have a reasonable chance to achieve them. And of course, when there is evidence to support our decisions and when we focus on the patient. And on the contrary, inappropriate polypharmacy would be the opposite thing. There are some tips we should follow to approach to the appropriate polypharmacy. We will discuss them later, but just to give you some slides, there should be a good prescribing. We should periodically review the medication of the patient. We should have a good system of dispensing and administration of the medications, of course, a great communication with the patient, and a periodical reconciliation of the treatment. So, in our population, we could say that there are two main roles related to polypharmacy. On the one hand, we have the young patient that has one disease that needs lots of medication, such as mental diseases. And then, on the other hand, we would have the older, old population that has lots of chronic diseases, and that's why they are taking lots of medications. Based on different studies describing polypharmacy in Spain, we could say that globally polypharmacy is more frequent in people older than 75 years and especially women. The prevalence of polypharmacy in Spain in year 2017 among people older than 65 years is between 27 and 37.5% according to different studies. As you can see in this table above, it's striking the difference between the type of drugs in both genders. As we can see, women tend to take drugs that are more related to mental disorders, such as anxiolytic drugs or antidepressant drugs. Another important thing to remark would be the adverse events during hospitalization. In another study that was made by the Spanish government in year 2005, they studied the adverse event during hospitalizations of the patient. And what they saw is that the 37.5% of those adverse events during hospitalization were related to drugs. The number was higher than the nosocomial infections and the post-operative complications. And to finish, I would also like to remark that in this table you can see the kind of drugs that are considered high-risk medications related to polypharmacy. And as you can see, these drugs are the drugs that we use in our everyday practice, such as digoxin, clopidogrel, or benzodiazepines, for example. So to sum up, we would say that polypharmacy is embroiled in a circle where the main problems that help its development would be chronic health problems. People would be older than 75 years and especially women. There is a higher rate of depression. They have low educational and social level, and they tend to make an overuse of medical care. So what impact does polypharmacy have on our population? Firstly, we have to think about the drug interactions and the adverse drug reactions, which are directly related to the number of drugs the patient is taking. As an example, a study that was made in Europe in the year 2013, they saw that there were 8.6 unplanned hospital admissions per year in Europe related to adverse drug reactions, and more than the 50% of those unplanned hospital admissions could have been avoided. Polypharmacy can also imply that the elder finds it difficult to manage their medication, so there is a higher risk of non-adherence and a higher risk of medication errors. Of course, there is a higher cost for the public health service, and we shouldn't forget that polypharmacy can precipitate or exacerbate geriatric syndromes such as falls or cognitive impairment. Something about the polypharmacy that needs highlight is the prescription cascade. It occurs when a new medicine is prescribed to treat an adverse drug reaction associated with another medicine that the patient was taking before. In this table below, you can see some examples of those prescription cascades. And I brought you some different examples to make it more illustrative. In this picture on the left side, you can see a prescription cascade that could begin with a patient taking an NSAID, such as ibuprofen, and finish with a fall. And now I brought you a real example. We have an 80-year-old lady with history of hypertension, osteoporosis, and osteoarthritis. She presented to hospital admission with acute delirium, 7 days of dry cough, and 2 days of severe diarrhea and lethargy. Clinical examinations and all the complementary exams were normal, except for the stool that was positive for Clostridium difficile toxin. Digging into history, we discovered that 8 days before admission, she started with dry cough, so she received codeine to try to resolve this dry cough. But instead of that, she developed a worsening in the cough, and she started with lethargy. And that's why she was given levofloxacin, assuming a possible pneumonia. And that's when that is what led her to start with diarrhea, renal failure, and that's why she came to the hospital. And what we discovered is that 10 days before, she had started a new drug for her hypertension that was enalapril. And as we all know, one of the adverse effects of the enalapril is a cough. So that is what led to this prescription cascade. I would also like to remark that sometimes we can't avoid these things to happen, but we have to try to think about the prescription cascade that might be hidden in our patients. So, based on what I've said so far, if I asked you who of those two population groups would be more vulnerable to polypharmacy, what would you think? Well, to answer this question, we can use one last prescription cascade based on metoclopramide and its disorder movements. If we gave metoclopramide to the young man in the left side of the picture, if he started with disordered movements, maybe it would be easier for us to think it as an adverse reaction, because Parkinson's disease among younger population is low. The prevalence of Parkinson's disease among younger population is low. But on the other hand, if we gave metoclopramide to the old lady in the right side of the picture, and she started with disordered movements, we might easily think that this is an onset of Parkinson's disease and start with levodopa to treat a possible Parkinson's disease, and this could lead to another prescription cascade that could end up with delirium or hypotension. So we can say that elderly are more vulnerable to polypharmacy in fact, and besides, they have all these risk factors that favor their vulnerability, as we can see here. The older age and the physiological changes that come with the age. Of course, they have multiple medical problems and geriatric syndromes that need more medications. A lot of these medications are considered high-risk medicines, so there are higher risks for adverse drug reactions. And on the other hand, elder people also have multiple psychosocial problems, they have sensory impairments, they normally have decrease in functional status, or they can have a decrease in their cognition status. So all these things can worsen the impact of the polypharmacy. So now let's talk about how can we approach to polypharmacy. I wish I could tell you there is a simple way to solve this problem, but it's a complex matter that needs a lot of time and dedication. And it's based in three main pillars: medicine optimization, the prescription, and appropriate polypharmacy. Those three are related to one another. And now we will discuss how to approach it. There are different ways to manage polypharmacy, and we've elaborated different steps. As we can see in the right side of the presentation, we should make a great medication reconciliation and check for drug-drug reactions. Of course, we should make an approach to meaningful the prescribing, and then once we've done that, we should start sharing our decisions with the patient, elaborate a tapering plan, and after that, monitor our changes. So first of all, we must focus on our patient. We should consider patients and caregivers' perspectives on goals of therapy. For example, we must decide whether we have to make a disease control, or we should control acute symptoms, or we should make primary prevention or secondary prevention. Once we have made our patient's profile, we should start with the reconciliation of the drugs he's taking. We should elaborate an accurate medication list, including herbal supplements and vitamins, and we should check for the adherence to see whether the patient is taking correctly the medication. After these steps, we should assess whether the drugs the patient is taking are indicated or not. And also we should try to consider whether the patient could make some lifestyle changes to avoid some drugs. And of course, after all these things, we should focus on possible interactions between drugs and to see whether there is a hidden prescription cascade that we didn't realize. And to help us assess whether these drugs are indicated or not, there are different tools, and one of it's medication appropriateness index, that you have some questions you should ask yourself to see whether the drug the patient is taking is a correct drug for him or her or not. Then, once we've done our profile of the patient and we know what drugs the patient is taking, we should start with the approach to the polypharmacy or to the prescribing. We should try to do it with all the patients we have, but especially with the pluripathological chronic patient, the ones that are in the end stage of their lives and they have severe functional and cognitive impairment, and where we have to control some symptoms instead of a disease. And of course, we should also focus on the patients that are taking more than 10 medicines per day, they have lots of high-risk medications, or where we already have seen that there are some drug adverse effects. And this can be done in two different ways. But what we must know is that we should combine those two things. On the one hand, we have the implicit tools, which means that where only the clinician's judgments is what matters. And then we have the explicit tools where we have some recommendations that help us make the decisions. And these explicit tools would be the BEERS criteria, the stop-start criteria, and the stop-trade criteria. There are plenty of different tools, but those three are the most known. And now I would like to give you some insights about those tools. For example, the stop-start criteria, as you can read in the presentation, they give some recommendations for us to stop or to start drug therapy. But it's only a recommendation. We, as I said before, we have to focus on the patient and see whether these recommendations fit to us or not. And one example of these recommendations would be the cardiovascular system recommendation. For example, they make an stop recommendation in the cardiovascular system with saying that beta blocker and rapamycin or DTSM shouldn't be mixed because there is a higher risk of heart block. And on the other hand, they recommend to start antihypertensive therapy when we have a systolic blood pressure higher than 160. On the other hand, we have BEERS criteria, which are similar to the stop-start criteria, but they also suggest which patients and which drugs are high alert medications for patients, as we can see in this table. And for example, they consider that patients with impaired renal function are high alert patients. The last step of this all would be to share our decisions with the patient and to elaborate a tapering plan, and after that to monitor the changes. But here we could find some challenges. First of all, the time. We don't really have enough time to explain all our decisions to the patient, and this could lead to the resistance of the patients to the changes. That's why we should try to find the correct space and the correct timing to describe all the changes and argument why are we doing these changes. Another thing is that, as I said, we don't really have a lot of systematic support to help us make decisions, and then sometimes we don't really know whether our patient's survival prognosis is high or low. Then another challenge will be the risks of the prescribing. First of all, we could have withdrawal syndromes or rebound effect, but those two risks are avoided if we elaborate a correct tapering plan. Such as stopping one drug at a time or lowering the doses progressively. Everyone should try to review patients' medications, but it's important to see that we have to make a teamwork. We have to work together with the clinicians, the nurses, and the pharmacy department to make a better impact in polypharmacy. I would also like to remark that primary health centers have a very important role in management of polypharmacy because they are in direct contact with the patient. But as we've seen in previous sessions this year, we can see that they are already doing a great work managing polypharmacy. And what is the perfect timing to manage polypharmacy? Of course, this would be during hospitalization or when there is a change in the health status of the patient. And these are some of the projects that are going on now trying to manage polypharmacy in the hospitalization. And I would like to remark one project that is being held here in Santiago that is called Conciliación y adecuación de la medicación en el paciente crónico, gestión de caso, abordaje multidisciplinar entre niveles asistenciales. And this is a project held by the pharmacy department together with internal medicine. And what we do is we make a meeting every Wednesday morning where we join internal medicine, the pharmacy department, and liaison nurses, and we discuss the treatment regimen of some selected chronic patients. The bottom up of this project that was made in 2019, we can see that we had 51 meetings, including 314 patients. 90% of those patients were taking 5 or more drugs per day, and we also found that there were 25% of errors in the reconciliation of the drugs during hospitalization. So with those 314 patients, we made 660 interventions. Most of them were related to the prescribing. As you can see in the picture, 43% of the patients were having drugs that were not indicated. In 21% of the cases, we saw that not only they weren't indicated, but these drugs were contraindicated for the profile of this patient. And we also made 25% of dosage modifications. And the drugs that were more commonly reviewed or that were prescribed were the proton pump inhibitors, benzodiazepines, then statins, and finally opioids. So to finish, I would like to give you some take-home messages. Firstly, that we must focus on the complexity of each individual and not only the age. Then we should understand that the number of medication is less important than the potential effect it can have in the patient. And that in some cases we may not reduce the number of drugs, but we can improve the appropriate prescribing, and that our principal goal would be to avoid inappropriate polypharmacy in the first place. Eta, bueno, eskerrik asko zuen arretagatik.